So week 5 is a hard week. Probably the most tested is your respiratory, whether it be whether it be children or adults. We know respiratory is a big deal. And cardiac in children, as I initially was telling you, it's a real, it's usually congenital. It's no cardiomyopathy, maybe, is probably one that might be an adult. But some are all of these congenital defects that we get. The CJ Sims, if you see a 0 and you did it, please go back and look at it. And it's because it wasn't submitted correctly. There's a form that you get. Your name's on the top, tells me the name of the Sims, the date, and your grade. Those 4 things must be there. I think only one student didn't have it completely correct. But again, no deduction. This is the first one. That's what I was doing right as we were getting into class, because I wanted to let you know if you saw a 0 that you could go back and get it. So I was telling you on a Monday, not storing it on a Tuesday or Wednesday and you're not seeing it. So, all right, let's go ahead. Any other questions at all? Let's do our PowerPoint. Now, I used to be a cardiac intensive care unit nurse. It is my absolute favorite area to work in. You know, I'm still known as Grandma Betty, who started the unit here in Miami back in the 90s. And I've worked with some amazing surgeons, Dr. Redmond Burke, who is a Boston graduate, who has done some pioneering in the field. So I had the pleasure of doing that. So it's near and dear to me. So if you want any explanation, I'll help you. So we're going to start out with respiratory. So URIs, right? Respiratory tract infections. Know that there's upper and lower. In children, remember that upper airway, it's that nose, it's into the ears, it's the dripping, it's the coughing. And then the lower would be more like your asthma, because it's the bronchioles and the alveoli that are just all in spasm and tightening up, or pneumonia. Most of the time, it is a virus. Now, RSV, you've heard of it if you've had children. You've heard your friends had RSV, the children. Now, RSV for you and me is a common cold. RSV on a young infant, usually below 1 year, and I say even below 6 months, they really have a hard time. So let me explain what that's all about. In RSV, there's extra secretions, low-grade fever. Now, how do children breathe? They're obligatory nose breathers. So put mucus in it, try to suck, swallow, and breathe, and they can't do it. So it becomes more of a problem and develops more into respiratory distress. So with RSV, it's a virus, so it's all symptomatic. So if they can't feed, that child would get an IV. If they still can feed, we would just suction their nose out before they feed and then give them their feeding, right? And then, you know, the acetaminophen for the child, for the fever, okay? Sometimes it's due to other stuff, but, you know, most of the time it is just upper respiratories, 90% of the time are your viral. Now let's look at the infant and the way that their body works and their antibodies. You know, you're born and you have all mom's antibodies in there. You have all mom's iron, you know, your hemoglobin. So even though you're still, you know, very susceptible, at least you have that basic foundation. Well, that stuff sort of goes away after a while. Red blood cells do go away after a while. And then the infant itself has to start. So after 3 months, you're going to see children getting sick. If you see an infant ill in that first 3 months, it's a high alert. That's what we call in the ER a red chart, which is 1 under trauma. So it is a very significant thing to have an infant not breathing well, sick, fever. We do treat them very seriously and very quickly. Now, as we get older, now the infants are getting all the immunizations. They are being exposed to everything. So now their body's making their own antibodies against it. So toddlers and preschoolers, this is where they're exchanging all of their germs, right? I call it the toddlers go to daycare or friends' houses and they play with toys and all they do is swap spit, which is they're swapping germs, right? So I'm getting all of those germs because they explore the world in their mouths. It's just normal. So again, they're going to have a high rate of viral infections. I have parents coming in every week. I remember when I was working in the ER, the last portion of in the hospital, every week when they first start, because they're now getting new germs they're being susceptible to. Now, after 5 years old, usually it's more of your bacterial, sort of things. And we know as you get older with immunizations and getting these things, the immunity gets better. Now, otitis media, we connect it all into respiratory because it's mucus that goes up eustachian tubes in the middle ear. And we always treat these as a bacteria, always a bacteria. So, what is our nursing care? Well, have you ever had an earache? It hurts. So, number one, pain control. Acetaminophen, ibuprofen. That's always your priority when you have a new ear infection. An antibiotic, one dose, is not going to take care of them. So take care of the pain first, right? We treat them with a course of antibiotics, make sure we teach those parents to check at the physician once they're done with it to make sure it's gone. Now, if you are in chronic ear infections and the mucus can't get out of there, they will do surgical. They'll put tubes in there. I just had tubes put in March. I have this one ear that just drives me crazy. So I've had them put in, and I know why they put them under anesthesia, because you can hear them suctioning the mucus. You can hear them cutting the little membrane. You can hear them squeaking that little tube in there. An infant, a child, a toddler is not going to sit there. So now I know why they're put under. They're wide, they're short, they're open. Where does mucus go? Area of least resistance, up the tubes. And that's why they get them. So what does a kid look like when they're sick? Well, a kid who's sick is that one who's not going to eat, is usually. Now, us adults, we're sick, we'll still eat. A kid, don't feel well, fever, they will not eat. And they usually are not playing aggressively like they normally are, okay? You see that anorexia, sometimes one vomit, a little diarrhea, and all the rest of these symptoms you can hear with it. But the greatest thing about kids with these low-grade fevers, with ear infections or whatnot, give them a dose of an antipyretic. 30 minutes later, they're drinking, which is what you want with any sort of fever, right? All of that water loss just because of the fever. So our goal, make them breathe easier, get them comfortable. Of course, today we even have the little kids putting their coughing into the arms, which I think is amazing. Washing hands. And again, hydration, that's going to help them feel better, and whatever nutrition we can. Now, infectious mononucleosis, it's viral. So no antibiotics here. They say it's our herpes like Epstein-Barr. They call it the kissing disease, right? No big deal. Wrong. What happens with mono is your lymph nodes get swollen. You might see it in the neck and the armpits and the groin, but your liver and your spleen can get large. And if we're not careful with that spleen protecting the abdomen, it's like a balloon putting a pin in it. It could burst and you will not be alive anymore. Now, how do we diagnose mono? It's very hard. This child will go to the doctor, fever, sore throat, aches and pains, flu-like symptoms, and these swollen glands. And the doctor will say, all right, let's do a strep test, let's do a this test and a that test, and they're all negative. They say, okay, it's viral, go home. 3-4 days later, they're still sick. Parents come in. We'll put them on an antibiotic. Of course, it's a virus. It's not going to work. Oh, about 7 days later, they end up into the ER. where now I'm working on the weekend. They come in and they give me these symptoms. And what we'll do is we're going to check them for mono. It is a blood test. We'll also do a CBC to look at the white count, right? Because white count's going to tell you if there's an infection. So usually monospot test is positive. And the big deal is to make sure that there's no PE. If there's rough housing at home, I had 6 brothers, so no rough housing for my brothers if I had mono, and protect the abdomen. No contact sports. I'm going to tell you a story to show you how significant that is. I was in the ER on a Saturday. Little boy came in, absolutely this scenario. 1 week later, I'm the primary trauma nurse on duty. We get a call. Kid fell off of an ATV out in the Everglades. He came in dead on arrival. It was this child, his spleen had burst. He had fallen off the ATV onto his abdomen, onto a rock, and punctured that spleen. So what are we going to teach our parents? Protect the belly. No contact sports until cleared by their physician. Now, bronchitis is one of those really irritating, annoying things. Usually it's a virus again, but many times physicians today do treat this one with Zithromax, just to be sure. But the thing about bronchitis, and you need to know, it's a dry, hacking, non-productive cough that worsens at night. You want to sleep, and all you do is cough, 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 cough. Now, sometimes you have a fever, sometimes you don't, but it's this annoying cough, and it doesn't let you sleep. So how are we going to treat it? Well, you can either, and I've told parents to do this, go into the bathroom, close the door, turn the shower on hot, and just sit there on the toilet and let the steam go in. And then just pack the back of the back of that child, and usually that humidity, or even one of those vaporizers can help. And then also a cough suppressant, only because to sleep at night. During the day, let them cough, let them get that stuff up, okay? Now, croup. Croup is a viral infection. It is a larynx, trachea, bronchus. There's all different things. Croup is that barking like a seal. It is very distinctive. A child will bark. You can hear him from, a mile away. Oh, that's croup. Many times it's the H influenza, which is a virus. So how do we treat it? Well, keep going. We'll show you some more. With croup, you have swelling, which is causing this barking sound. We treat it with a steroid, whether 1 dose or IM dose, PO dose, or a couple days of something like prednisolone, the liquid stuff, twice a day, once a day. Now, every physician does it differently. Now, usually croup, you've had some sort of upper respiratory, right? Now, you can get that inspiratory stridor. Now, inspiratory, expiratory, oh my goodness, how do I remember? Well, it's all upper airway croup, and it can't get in. That swelling of the epiglottis and all of that area creates that inspiratory, that trying to get air in, okay? And that causes retractions. And when they bark, it's their it's an expiration versus an inspiration. So it bark, bark, bark. Now, if we don't treat croup and we let it keep going, it can cause, respiratory failure. So this is something, though, the kid looks okay, he's just barking. This is a child we give a steroid to, and then they do very well. Now, sometimes this croup becomes the worst thing it can be. Now, in the back of your throat, there's this thing called an epiglottis that covers the trachea when you swallow liquids or you swallow food, so don't go in your lungs. Well, this epiglottis gets so big and swollen, it covers the trachea, air can't get into the lungs, so you can't breathe. So think about what this child would look like. If they went to talk, they'd be really muffled. Their throat's going to hurt. they're going to be in that tripod like those adults do, those COPD adults, like leaning over, trying to find position where air can get in there somehow. Again, inspiratory stridor if they can get some air in, and then the retractions that go with it. This is a emergency. So this child, if you get an epiglottitis into you're caring for them, get an intubation tray and a tracheostomy tray at bedside, because sometimes they need to do even a trach. They can't even get an endotracheal tube because the epiglottis is so swollen over it. So what do we want to do? Well, epiglottitis, we need to get an IV in because we need hydration. We also need some IV steroids put in. And at the same time, we're giving a racemic epi aerosol, going epi right into that epiglottis to try to get the swelling down there. And usually that works. I have never gotten to the point of having to do a trach yet, but you have to be quick because by the time they get to you, usually they've been barking for a while and they're really in respiratory distress. So RSV, we've talked about it a little bit. We know it's a virus, but RSV, as I said, in the young kids can be very dangerous, right? Well, what if you're also a congenital heart defect? What if you're a cystic fibrosis? What if you're immunosuppressed in any other way? You don't want that child to get RSV, and there's a way to prevent it. There is a monthly vaccine called Synagis, which is palivizumab. It's a biologic. Once a month from winter to early spring. It's not about 8 months. I live in Florida, so what is winter to early spring here? But usually they'll figure out, when it's a little bit cooler here versus. But that's a name you got to know. You're going to see it again. Synagis, palivizumab. Now, many kids, what do they get? Sore throats, ear infections, and many times they have to have tonsils, adenoectomies, and their tubes put in all at the same time. So tonsillectomy, how do we treat these children coming out of surgery? Well, and what are we going to teach these parents how to take care of them? Well, if you can think, these tonsils are these things that are outgrowth, and the adenoids are there also, and they're outgrowths on the throat. And they literally cut them away and cauterize the area. And a big scab forms. So we need to protect that scab from coming off because they will bleed out, and I've seen that. So avoid irritating, high seasoned foods, no vigorous anything in the mouth, whether gargling, toothbrush. Now, they also say try not to cough, clearing the throat, and no straw, nothing. So it does hurt. So something for pain. They used to send them home with a narcotic pain medicine, but they found out the parents didn't know how to use it properly, and the children really only needed acetaminophen or an ibuprofen. In fact, they preferred acetaminophen, so there's no bleeding, which is involved with NSAIDs, right? Also, if the child will keep it on an ice collar, the young kids won't. The older kids will. Limit activity, and then older kids remember, this is all interconnected, those gestation tubes, they get ear pain. I get a little swelling in there, it goes on post-surgical, and they say chewing gum, just like going up in an airplane. It helps pop the ears and prevent that pain. If they're having moderate mouth odor, little ear pain, little low-grade fever, we expect that. If it goes on after 10 days, that's something that needs to be expected. And then if it's, more than usual, more of a severe headache, fevers are really high, or they're coughing, again, that child is going to have to go back to the doctor. And usually it's 1 to 2 weeks and they're back to normal. Now, pneumonias. Well, we have pneumonias that are, consolidations in the lungs due to a bacteria, due to a virus. And also we have inhaled and we also have aspiration pneumonias. There's a lot of different pneumonias that we can have. And there they are. And we do have the pneumococcal vaccine now that we do give our children. So aspiration pneumonia, talking about the changes in nursing care that I have seen in my career, we used to love to put baby powder on our babies in their diapers because it smelled so good. We didn't realize that the talcum was floating in the air and they were inhaling it and causing respiratory problems. So no more talcum powder. And I used to love Johnson and Johnson. The smell was so great, but nope, don't do it anymore. That's one of them. Another one is feeding. Now, reflux is a big thing. GERD, they're aspirating. So, what do we need to teach parents? We need to teach them how to feed, not to overfeed, how to burp accurately and effectively, and having them sit up after their feeds. Okay. And that does seem to have helped with those aspiration pneumonias. And of course, if you're in there cleaning the bathroom with bleach and borax or whatever you're in there with, I would never have a kid in there. I mean, I've even seen students tell me they were in there cleaning the bathtubs and now they have an aspiration pneumonia. Their lungs have been so irritated from the chemicals. I can't imagine a kid getting it. How do kids explore the world? With their mouth. What do they do with coins? What do they do with everything in the mouth? Remember, safety, safety, always making sure the size is big instead of smaller. Well, the most common coin a child swallows is a quarter, believe it or not. And that picture right there, I can't even tell you how many I've seen. Now, years ago, we would put an IV in and we'd send them to the OR. They would do a bronchoscopy, take a little claw, pull it out, and you were done. That's an OR. That's an overnight. Do you know what we do today? We take a Foley catheter with a big balloon on the end, and the surgeon puts the child in their lap, and they put down this catheter to go down below the coin, blow up the balloon, have them lean forward, tell them to cough as we pull, and usually they vomit and the coin comes up. Now, that's scary to a kid, right? Well, I tell them, you're vomit, but the coin's going to come out. And if I get it first, it's mine. So now it's a race to get the coin. So now their mind is switched from, oh my God, what's happening, to I'm going to vomit. Let me get it first. And they fly off that surgeon's lap onto the floor and it's mine. And of course, they'll have to wash their hands. But do you see how you play a distraction there? It
What about
works.
trauma for that
It
part?
works really good. It works great.
Okay.
Pertussis. Yeah, it's been wiped out forever due to immunizations, but a couple of years ago, we had an outbreak down here in Florida, and it's extremely, extremely contagious. Now, it's because there are some children who don't get immunized due to whatever their parents' beliefs are. They're not. So, when we get young children in that are with upper respiratory and coughing, and you're suspicious, always put a mask on yourself. Protect you, and if you suspect the child pertussis, get them into one of those airflow rooms, just like you would do with chicken pox, because it's airborne, okay? Smoke inhalation can happen. Um, Usually they come in and it's just 100% oxygen. Just keep them on that and get it going. I've actually seen older patients sent up to the hyperbaric unit when I worked in an adult ER. So depending on how severe it is, again, smoke inhalation, if there's fire, always worry about oral airway. Was the oral airway burnt? Is it affected? Is it going to deteriorate on you? Smoke, we know that nobody should smoke around children. It affects them in so many different ways, and even if you're pregnant, so we recommend them not to. Cystic fibrosis is a dual organ condition, right? It is the lungs are don't work right and they collect mucus in the bases, like petri dishes. So these are always growing or can easily grow bacteria. So cystic fibrosis can be diagnosed at birth, even if we didn't know the parent was carrying a trait. And the way is, this would be one of the children that would not have a bowel movement. move their bowels, meconium, nothing in the first 48 hours, 72 hours of life. Most infants come out and poop right away, right? Well, this one wouldn't. This is one of the cases. And then we would test them. And all we do is a sweat test. And what are we looking for? That very salty tasting skin, sodium comes out. They sweat their salt in all their pores. So the sweat test measures sodium levels extremely high. Okay. As I said, frequent lung infections, they got petri dishes, their lung sounds are going to be horrible. Now, the other part of cystic fibrosis is in the small intestines, and they have an inability to digest food. The pancreas don't work correctly. This is going to be required to take this pancreatase medicine before all meals and all snacks. And it helps with the digestion. Even with this, they don't digest fat. So fat is the highest calorie thing, right? So these children are skinny and small, and you have to load them up on carbohydrates and proteins, okay? And fats, if we give them too much, they're going to have loosey, greasy, foul-smelling stools, okay? Now, there is a big thing about the pancreas medicine. Now, some of them come in little capsules, some are powder. What we can, and some are these little beads that are inside these capsules. Well, of course, anything enteric we never crush and give because it has to be a time release, right? Now, open the capsule, sprinkle on the food, and they can take it as they're eating. Powder, same thing. But the big thing with powder is just like those inhale medicines that you have to rinse your mouth after to protect the teeth. Same sort of concept there, okay? So we treat the digestive nutrition part with pancreatase medicines, high carbs, high protein. We will never hold a salt shaker on this child. They are spewing salt out their pores all the time, okay? So high sodium will give these kids. And of course, these children are beyond aggressive pulmonary care. I mean, they'll be getting aerosols morning, noon, afternoon, at night, and during the night if they need to keep it loosened. And of course, antibiotics, whether orally or in the aerosols, to keep their lungs from being infected. So those are all the things. So one of the things with cystic fibrosis is these are normal, alert children. And many of them want to get pregnant. Now, a woman can get pregnant, high risk, but a man with cystic fibrosis cannot impregnate the woman. There's something about the vas deferens and the mucus, it clogs it, and sperm can't get to the woman. So, and this was a HESI question. Pregnancy is possible for the man 1 year after bilateral lung transplant. And many men are willing to do that in order to have their own child. Can you imagine? Oh, let's go for a bilateral lung transplant because I want a
What about
child. It's a big
what
risk.
about IVF for that instead of like lung transplant?
They can't get to the sperm. They can do IVF. The woman can get pregnant. The
Yeah.
woman can get pregnant. The man can't give her the sperm. The sperm doesn't come. It's all clogged in there. I mean, maybe they can go inside the testicle and get it. I don't know. That I've not read about yet.
And you said that's a HESI question usually?
Yes, the men 1 year after bilateral lung transplant. I've seen it before. I've had students tell me. Sleep apnea. Do you know anybody who snores at night? I do. Anyway, it's sleep apnea is a partial obstruction. And remember, if you don't sleep well and you're always with the snoring, you're not going to sleep well, and in your daytime sleepiness, etc., is going to happen. What you do for sleep apnea is you do a sleep study, and then they sometimes younger kids, the TNA, tonsils and adenoidectomy, clear that up. In fact, a lot of times it's why they do it. Older kids might need to have that machine at night, that helps them breathe, just gives a little bit of pressure. And as soon as we notice it, we should absolutely get it done because it's, disruption in the sleep pattern. ARDS, one of the most acute lung injuries that you'll see. It's due to overwhelming infection, sepsis, trauma, drug overdoses, and even near drownings that have fluid has filled up, water or whatever, into the lungs. And these are your sickest respiratory children that you will see. Most of them die. And this is a picture of ECMO. And it's a newborn child here. I got certified as ECMO. And it's a machine that pulls out blood, oxygenates it, and reinserts it back into the child. And if the lungs were damaged, they can let those lungs heal. And then slowly they wean the machine, the ECMO, off and let the child breathe more and more and more. But it is an extremely ill child. You'll always see some sort of question about CPR on exam. So I always tell you to review that. Also, remember in pediatrics, and even in adults, there's always somebody or can be somebody in the room that, you have to throw out because, everybody's running in. I mean, we try to keep parents next to children with CPR, especially if we know an outcome maybe not be great, so that they can, be there holding their hands if their children die, or have somebody standing with that parent, making sure that they're taken care of. It's extremely emotional. Anybody have asthma? Asthma is all expiratory, okay? These are types of questions. Inspiratory stridor, croup, epiglottitis. Expiratory asthma. What happens? You can get the air in, all the upper airways open. It's down below, swollen. Air gets trapped, and you hear it trying to get out of the lungs. So when you have been diagnosed with asthma, and they say it's like 2 years old again, that number of 2, where they'll finally diagnose you with asthma. But what they'll do is figure out how your lungs are working, pulmonary function tests due to an allergen. They'll do those skin testings and try to get you desensitized to those things. But with kids with asthma, because you have asthma doesn't mean they can't be normal sports, etc. But they have to make sure that they're smart. They have their little rescue, their little albuterol, Ventolin, Proventil. All 3 names are the same, so they can do their rescue. With asthma, they're going to getting those morning and night things. Now, in children, it's called Pulmicort. Adults could be called Atrovent if it's aerosols. In adults, Symbicort, Rio, Advair, all of those morning and night has a little bit of steroids in. They're preventative. They're not for an acute stage. The quick relief is your albuterol. And then, of course, corticosteroids if we need them, those steroids that will help decrease that inflammation. And the cromolyn is what I was talking with the Ventolin, with the Atrovent. So staph asthmaticus is very scary. My husband had it a few years ago. He was in the ICU for 12 years, and he could breathe out, and all I could hear was and that's all I could hear. And he was in the ICU with his nasal flaring and retractions and whatnot. It is an absolute emergency. He was like almost on continuous aerosols. Then they put him on a BiPAP machine. Thank God I didn't get him intubated. I was able to talk him down. And in children, remember, you can calm them, put them on the parent's lap, calm them down. And we know status asthmaticus, we're going to be giving those aerosols, and we're going to be giving steroids, and that should help bring them out. COVID depends on what's going on. Again, COVID's a virus. It's supportive care, just like viral pneumonia, supportive care, RSV, supportive care, and again, immunizations. So that's respiratory. Let's go into the hearts. So babies are born, and it's amazing that hearts are mostly normal. If you think about how they make a stalk and turn and twist and go over and twist around during, interutero, it's amazing that they don't come out all messed up, but most of the time they are correct. Now, that's a congenital. Sometimes after you're born and you're living and you acquire a cardiac condition, it could be due to an infection. I've seen viral infections attack the heart, cardiomyopathy. Now you've got a heart, that's big and swollen and floppy, and most likely will need transplant. Of course, autoimmunes. Think about lupus, right? It can affect the heart. Environmental, and of course, any family, the hereditary there. Now, I'm going to try to describe something to you by using this picture. So this picture shows you the heart. Do you remember all of the landmarks in the heart? I'm going to go over it briefly. You have the vena cava that feeds into the right atrium. The valve between the right atrium and ventricle is the tricuspid valve. Then it goes up through the pulmonary valve into the pulmonary arteries into the lungs. Then it comes back through the pulmonary vein, and there's 4 pulmonary veins. I always thought there was 1. There's actually 4. Goes into the left atrium, through the mitral valve into the left ventricle, up through the aortic valve, up through the aortic arch, and to the body. Okay, so that's the basic. You'll hear questions about tricuspid valves, aortic valves, mitral valves. So these are things, that you should refresh on if you haven't already. Now, what happens if you look at the picture, the left ventricle, you got that red coming up over, you have the 3 upper going up to the upper bodies, and that arch coming down. What would happen if that kinked? It was narrowed. Blood can't go down that way. What do you think would happen to the blood? That's called a coarctation of the aorta. Do you know what happens? It goes backwards. It stretches the left ventricle out, goes up the left atrium, and then area of least resistance, fill up the lungs with fluid. So coarctation goes backwards. Think of a garden hose. If it's kinked here, it's going to go backwards and squirt at the faucet, right? Same concept here. Coarctation, think about it. Nothing or minimal blood's going to the lower extremities. What do you think those blood pressures are going to be? Low. What do you think those pulses are going to be, if you have them? Minimal. But remember those 3 little things going up to the subclavian, etc., carotids going up to the upper? You have a lot of pressure going up that way. Older kids might have headaches and nosebleeds because of it. Also, because all the extra blood pressures are higher on the upper extremity. Again, that's another question for you. Upper extremity, higher, all the blood's there. Lower extremity, lower, blood's not getting there. How do we treat it? It's either a cardiac cath, we balloon it, or it needs the surgery and we need to resect it, etc. So what do you see with a child with cardiovascular dysfunction? Now, some of them are obvious when they come out, and we know that they're blue, and we get that. They're cyanotic. But some of them, that coarctation specifically, they are 2 months old, and they've always are getting tachypnic, and the parents think it's upper respiratory, and they're in hospitals that don't understand congenital heart defects. And it's real. Most adult facilities have no clue. I've worked in adults, so I know that they didn't have any clue. But you would see these children, and eventually they would get to where they needed to go, but they're not going to eat. Why? They're not getting, oxygen the way they should. Their lungs are filling up with fluid, right? you're going to see them tachypnic, tachycardic. They're trying to work hard to get oxygen, and it's still not working. And it's burning calories like crazy. So, failure to thrive. They're not getting enough nutrition because they can't eat. They're falling asleep. They can't eat that much. Their weight's going to be poor, or they're going to lose weight. Activity intolerance, which means they're not going to be eating. And because no nutrition and oxygen deprivation, developmental delays. I had a girl who came into me at 3 months from the west coast of Florida, went through exactly what I just said, and she was a really bad coarctation. And they fixed her, and after we got that left ventricle feeling a little better, she did very well. So one of the nursing diagnoses here could be inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. Does that make sense now? These children, let's see what their weights are, their colors. Let's look at their chest. You know, clubbing of the fingers happens later on. I've got a picture coming up. What do? We're going to look at all of these things. Look at the chest, abdomen, visual inspections, and percussion. Pulses. I've actually, when I was very young into the cardiac world, I actually found a coarctation. I couldn't find any pulses in the lower extremities before the doctor did, so I felt pretty good about that. Looking at the heart rate character, is it slow? Is it fast? Is it irregular? And breath sounds. Are there murmurs? We'll do an EKG, an echo, and if we find a dysfunction anywhere, something's wrong, prepare those parents. They're going for a cardiac cath. And that cardiac cath is a diagnostic to go in there to figure it out. Interventional is when, and I think this is a great example, Dr. Fishbinder on Wednesdays used to do his interventionals on children who had these episodes of SVT or elevated spurts of elevated heart rates. And when he went into the heart, he made it go into that heart, elevated heart rate, and he would zap it with a laser. And that's called an EP study or electrophysiology studies. But mostly we do diagnostic. So you're sending a kid to the cardiac cath. Most children we feed up to 4 hours before, infants 2 hours before if they're breast milk. Because remember, their sugars aren't going to hold. You send them away, they come back. Now, how do they do a cardiac cath? They take 2 big catheters and put it in the right femoral artery and right femoral vein. So when they're done with the procedure, they pull them out, apply pressure, put a pressure dressing. Older child will have a sandbag on it. Now, the first thing I'll always check, no matter what, is their dressing. Especially the infants this big. Can you imagine how quickly through a femoral artery and a femoral vein they could bleed out like crazy? I want to protect them. So I check that dressing first. That's your biggest risk, is bleeding, okay? Then I'll check for pulses. And remember that that right leg might have slightly decreased because of the invasion of those 2 catheters, okay? We're going to do the vital signs. They can have oral if they're awake and alert, or IV if they're not. And of course, especially young kids, their glucose. Did they get enough sugar during the procedure? So congenital heart disease, the number 1 is your VSD. VSD is what? There is a septum in the middle of all the chambers, the atriums and the ventricles. It's the middle of the heart. It's called the septum. And there's a hole. So blood is flowing from the right to the left side. It's on the bottom of the heart. That's the ventricles. It's a ventricular septal defect. If it's on the upper atriums, it's an atrial septal defect. ASD, VSD. Many of these are your trisomy. Your Downs children are the highest incidence of congenital heart disease. They're also very high in leukemia, believe it or not. So we have a VSD, they still oxygenate well, not a problem. But we do have some, and we're going to go into those that are not getting oxygen where it needs to go. And the one thing know about what shunting is, we know that blood just gets back to the right side of the heart. It's the last way of that heartbeat to get it in there, right? So the pressure's low. That left side has four pulmonary veins slowing blood into that left atrium. So we know if there's a hole in that atrium, it's going to go over to the right side, and blood's going to be reoxygenated, right? It's going to go back into the lungs. It's a mixing. It's just what it does. Same thing with the ventricle, the VSD. It's going to go back to the right side. So again, where does it go? Area of least resistance. Think about where pressures are higher or lower. So increased pulmonary blood flow, like I just said, ASD, VSD. Another thing that we have is fetal circulation. We have a patent ductus arteriosus. And this is what keeps the baby alive intrautero, okay? And what it does, it connects the lungs, the pulmonary artery, to the body, the aorta, and it allows oxygen to go to the body, okay? And again, it could go both ways after birth. Now the heart's beating and pumping, more efficiently. So, patent ductus arteriosus, it is there at birth and usually closes within the first 3 weeks of life, usually a day or two, but it can go up to that more. Obstruction, I just told you the biggest one, coarctation. And then what if the aortic valve was not working good? It was small. That's called a stenosis. Any narrowing of an area, it's called a stenosis. If an area is completely shut, no blood flowing, no matter what, that is an atresia. And that's your tricuspid atresia. No pulmonary blood flow. And why is that? Well, and the valve between the right atrium and ventricle, there is none. Blood can't get to the pulmonary valve and go to the lungs. So that's decreased. Now, the other one is, and this is the cardiac condition on your HESIs and your NCLEX, the tetralogy of Fallot. Let me try to explain it to you. Blood goes into the heart and it goes up into the lungs through the pulmonary artery, through the pulmonary valve. That pulmonary valve and that area, something covers it, kinks it, and blood can't get to the lungs. It's called a TET spell. They turn blue. They can go from an oxygen saturation of 100 and they can go to 10 like so quickly. It's incredible. So what is our initial treatment? Well, it's what we call knee chest. Quickly, you take the knees and the chest and you bring it up on the side or up, doesn't matter. And what that does, it changes the abdominal pressure and the chest pressure, and it allows it to pop open and blood to go back to the lungs, okay? That's all you need to know about that. And then we have something called transposition of the great arteries. The aorta and the pulmonary are switched. So you're getting no blood to the body. The lungs work and the body works and they're not mixing. So the only way that child can stay alive is if there's a connection. And didn't I tell you that patent ductus arteriosus will keep it from the lungs to the body? So we'll keep going. Patent ductus arteriosus, from the artery to the aorta. It is normal in the womb, and we keep it open for things like transposition of the great artery. When you listen to the chest, it sounds like a loud washing machine murmur. The other thing which is so significant is their blood pressure. Now, normal blood pressure on an infant is 60/40. Look what happens to the bottom number. The diastolic number goes down to 18, 16. Very wide pulse pressure. So sometimes, like that transposition of the great artery, we need to keep that open, don't we? And didn't I just tell you it closes up to 3 weeks after birth? So there is a medicine. It's a medicine you need to know, prostaglandins. And what this does, it keeps the duct open. It lets the heart beat and it keeps oxygen going. Now, sometimes, and I've seen it mostly in your very premature infants, and some older ones, but usually it's the premature, their PDA doesn't close at all. They don't need it, they're fine. So we can actually close it through medicine. And we give something called indomethacin, and that will close it. Usually 3 doses. Sometimes we might repeat that once, but it's 3 doses. And if that doesn't work, we'll do a thoracotomy as a side cut, go in there, and we'll just put a staple on it and clamp it. What's neat is if we're giving indomethacin, as a nurse, you can listen to the murmur disappear, and you can watch it diastolic number come back up to 40 as it closes, so you know it's closed. Right. Some of these, there are pictures for you, and I've left them there, but I've explained it already. So congestive heart failure. Well, that's what happens with coarctation, right? The heart's not beating properly, pumping right, oxygen's not getting where it needs to be. And if we let this congestive failure pumping against all this pressure, that muscle is going to become floppy and weak and give up, right? Damaged, I call it weak. You know, it's like running a mile and going 2 miles and you can't go no more, you fall to the ground. Same thing, the heart does the same thing. And it could be because the right side's not getting the blood up to the lungs, or the left side is not getting blood to the body. Either or, it doesn't matter, right or left. You're going to see, of course, the lungs are full of junk and all sorts of, you'll see tachypnea and tachycardia. You might even see decrease in urinary output. What do you want with, you see, in congestive heart failure? I mean, sometimes children go into it on your watch, and you would see a sudden weight gain because now that fluid's not getting around, it's collecting in the lungs. So that might be the first incident. Oh, they gained weight. What's going on here? Oh, they're breathing harder, faster. Oh, they're retracting. Oh, they're flaring. Okay, that child is in congestive failure. So what do we want to do? We want the heart to beat as best as can. And we want to get rid of fluid and sodium. How do you get rid of fluid and sodium? A diuretic, right? Furosemide, you know, Lasix. It is the most common of all of them used, and it works well. And getting rid of all that fluid helps. Also, if they're in really severe, we're going to do everything to keep the kid quiet, which probably means this child will get a tube feeding versus orally. They can't do it. It's too much. And then, of course, give them oxygen to improve tissue. Now, many times with congestive heart failure, to make the heart beat better, stronger, slower, more effectively, they give digoxin. Now, digoxin is very safe. It is just like adults. Count the apical pulse for a minute. Check the potassium. If it's low, don't give it. Check the digoxin level. If it's high, don't give it. If they're vomiting, now infants, the only thing you may see is vomiting. Their heart rate may be okay, but all they see is vomiting. Always, if they're on digoxin, say, let's check a level or call the doctor, right? So with all of this and getting the congestive heart failure gone, improving the heart, getting rid of that fluid, again, keeping nutrition. Nutrition's always, because remember, cognitively, they still need it. We know infants grow a lot in those first couple of months. And this is those young kids in congestive failure I'm talking about. Hypoxemia can happen in children who have, you know, one of these obstructive flows. If they have a problem like tricuspid atresia or a hypoplast, or, you know, one of these where one of the things is not open and the blood can't flow around like it should. And of course, we do surgeries to give all the oxygen we can, but there still is lower than normal oxygen saturation. Now, a hypoplastic left heart is probably the most severe of all of the cardiac conditions. The left ventricle doesn't work. It's thickened, it's muscular, and it doesn't push anything out to the body. So that's your biggest one. And you have hypoxia, you have cyanosis as they get older. Even with all surgeries, we have usually those initial hypoplastic infants can be born with O2 saturations in the 60s. And that's okay for them, believe it or not. As we do these 3-stage surgeries, they might get up to 90, but still, that is hypoxic for normal limits, right? So what happens when your body doesn't get oxygen? The body says, I need to make some red blood cells. Red blood cells is going to make me have more oxygen get to my body, right? Well, you have all of these red blood cells, your hemoglobin hematocrit 18 and 54, because your body keeps making these red blood cells, but there's no oxygen, so they keep making red blood cells. So that's what polycythemia is, okay? Again, I want to tell you, cardiac families are probably some of the nicest people you'll ever meet. Again, as you're doing examinations and doing assessments, telling these parents, these mothers, these fathers, these children, siblings of these patients, teach them, because they're their eyes and ears for us at home to keep them healthy and safe. I've already gone over that. Bacterial endocarditis can happen. It's just it's a bacterial infection. It does require antibiotics. Remember, this is the one that needs prophylaxis, dental treatment. If they're coming in for a cardiac cath, they're going to need a dose of antibiotics before procedure. Rheumatic fever is a fever, a sore throat. It affects joints. It causes, skin rashes. It causes problems and can lead to heart valve damage. And it's all because a strep infection was not completely treated. It's a strep infection that attacks your body. And then it gets to the point where you have chorea. You're unable to move your arms and legs the way that you should. Now, what is the treatment for this? Well, if a child came in, rash, sore throat, this chorea, and we're seeing all the symptoms, has your child been sick recently? Oh, they had a sore throat a month ago. Oh, that's when we know we're going to do one of those ASO titers. It measures strep in the blood. And if it's positive, we know that it's the strep infection causing rheumatic fever. How do you treat a strep infection? How would you treat rheumatic fever? An antibiotic. And it's long term. It could be a month, 2 months, 3 months, depending on it. And everything, even the chorea, all of those things, all will go away, except if your heart valve, which is the mitral valve, is damaged, then there's nothing we can do with it. So we need to get this treated as soon as we can. They can get high cholesterol. We're finding these things out. We never used to test it before. They can have cardiac dysrhythmias, too fast, too slow. I think the smallest child I saw with a pacemaker was like 1.5 years. The pacemaker was a little tiny little thing, and they do work. Pulmonary arterial hypertension. This is very similar to adults where the lungs, the alveoli just collapse and they don't work. No oxygen, no carbon dioxide is exchanged for whatever reason that happened in, maybe overflow. It's the body's protective device to protect the lungs, and it ends up hurting the person. So have big oxygen here because everything's tight. You see the difference between the open valve and the pulmonary valve. That one, you're not getting as much oxygen. So what do you see? Of course, dyspnea with any exertion, chest pain because you're trying so hard, and you're deprived of oxygen, so you're dizzy, syncope. As I said, cardiomyopathies can occur even due to a viral disease or anything else, and transplant is usually what we do. The largest reason for death in transplant is rejection. Okay, rejection is it. It's not infection, it's rejection. And they'll be on lifelong immunosuppressants. Now, in the cardiac surgery, they always have a chest tube, 2, 3, 4. I've seen 5 in small little children even. And that's to keep all the area, free of any sort of, blood, etc. Now, children, small children, we have to take these chest tubes out. Infants, yes, we'll give them something for pain, absolutely. But small children, that's the one that we have to be more careful with. Yes, you'll take the vital signs because we're going to medicate them with pain medicine. And that's your priority. That physician, get away until the pain medicine's in and give it a little bit of time to work, right? Then with the child, again, get on their level, let them know what it's going to do, and don't lie. It burns, but the pain medicine does help. And it's like briefly, I used to work also in the cardiac open heart area. And every morning, and I worked night shifts, 6 a.m., they came in to pull tubes. And the patients did tell me it burns, but it's like 20, 30 seconds, and then it just eases away. So those are some hints. We check blood pressures now on younger kids than ever because, elevated blood pressures can kill kidneys and hurt hearts and everything, right? So we do check them earlier. Kawasaki disease, this is another viral disease. It's a systemic vascularitis, which means the veins and vessels get inflamed. And the biggest concern with Kawasaki is that those vessels of the coronary artery get weak and they outpatch and cause an aneurysm. Okay, that's the biggest concern. This is what they look like. And I loved working in the ER and finding them and diagnosing them. I'm somewhat of a nerd. I like to find things before the doctor does. And Kawasaki disease is a difficult one. But you'll see red eyes, they glow in the dark, right? These big red lips, strawberry tongue, sometimes swollen glands. The palms and the soles of the feet blister and crack. That is part of it that you might see. So it's a vascularitis. What do we do? Well, microembolies and all sorts of stuff are going on. So high dose aspirin, only time you give aspirin to an infant that you know of so far, okay? High dose aspirin. And what it is, it's an anticoagulant. Sometimes some physicians might just say, oh, just put them on Coumadin, but high dose aspirin works very, very, very well. And then to boost their immune system, we put them on some IVIG, or intravenous gamma globulins, and that does help. And it's usually a month of treatment, and then they do all right. Shock. Shock in children is usually due to infection. Children don't handle infection well. And infants, they first will tell you they're getting infected by periods of apnea and bradycardia. They don't even show a fever yet, believe it or not. Anaphylaxis can happen. Remember, we're giving antibiotics for the first time, aren't we? And this all can happen. So we're going to treat it just like adults. We're going to give them the epinephrine, and we're going to do whatever support they need in order to get them through. As I said, septic shock is the big thing that you will see. And again, it's getting those antibiotics in and keeping them well oxygenated and their blood pressures where they need to be. Many of them do need to be placed on some sort of blood pressure medicine. Their bodies are so overwhelmed. Toxic shock, these are for your more adolescents. It's tampon use. It's something that came out when they started mass producing different types of tampons way back. I remember it. So, question, think about this. Surgical closure of the patent ductus arteriosus would result in which of the following? What is that patent ductus? What does it connect? It connects the aorta to the lungs, pulmonary artery.
See?
So you would see an increased oxygenation of blood. And yes, absolutely. And it actually prevents return. So the blood can't go back up into the lungs. So preventing return of oxygenated blood to lungs. If somebody had a question.
I was about to ask, can I turn my camera off for a second to put my daughter down for a nap? She is screaming.
Go ahead, take care of her. I understand that. So a lot of stuff, huh? A lot of stuff that's in there. And it's a hard chapter. I think that matching has all those key things, that you need to study. Anybody who's not getting what I said, I try to make it as clear and simple as possible, but I know it's difficult. I mean, I worked in the cardiac ICU for 10 years. That was just the ICU, and then an NI for 10 years before that. So it's 20 years of figuring it out, right? All right, who wants to win a Kahoots today? It's a little bit hard. It's all about this good stuff. There you go. I do give a lot of questions in this area because it is that topic that's really hard to understand. And I think the repetition of those questions will help.
Did you get my message?
Which message? About
Um,
about you.
yes.
Okay, I understand. Yes,
Okay. I'm sorry. I just realized what time it was.
it's
So,
okay.
okay. Thank you.
No, you're welcome. All right, let's get going. Week 5. I need it. A majority of upper respiratory infections are caused by what? Again, viruses. Upper respiratory, they'll definitely, number one, they'll treat you like a virus. Symptomatic. Fluids, antipyretics, rest. You walk into a 6-year-old child's room and you find them not breathing and does not wake up. What are you going to do? Now, because of the way these questions are, the first appropriate answer is to start compressions immediately, right? And then call for help. You're going to do your cycle, call for help. You never leave an unresponsive child. No. I'd be screaming or pushing the button over the heads of their beds, right? A multi. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? All of the above. They're the type that sits in the corner. They won't eat, and you could tell something's wrong with them. And then sometimes it's just they vomit once and sitting there. They, it could be all of the above or one of them. A multi. What do you look for when assessing respiratory function? So you're looking at a little bit of everything. When children are great, you can look at them, just inspection by looking. And if we see that they're pulling between their clavicles, supraclavicular, it will, adults don't do it. In children, you'll see it pulling back on every breath, and you'll know it. Another thing with children, especially small, nasal flaring. And then if you've got a small infant in severe respiratory distress, as they breathe, they'll grunt. So they'll breathe. Eh, eh, eh. And if you hear an infant breathing like that, you better take them to the trauma room. That child is extremely ill, okay? It's happened a few times to me. What would you look for after a child has a tonsillectomy? So remember, they cut those areas out, cauterize them. There's big scabs in the back of their throat. What's your biggest concern? And it's the bleeding, right? And what they'll do is they'll start swallowing because they're bleeding. It's the back of the throat. They'll swallow. Doesn't mean it's coming out of their mouth. They're swallowing it. So yes, very good. Another multi. Nursing care for a child status post tonsillectomy include? Remember, all of this is age specific, an older kid, you'll be able to take and use that ice bag, right? Or an older child, because of the ears are popping, they can tell you they would do the gum. So no spicy foods, everything else, yes. And remember, the gum is for the older children because your eustachian tubes get blocked from swelling and it causes ear pain. The gum is chewing like going up in an airplane. It pops them, it lets the pressure out. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? All night long, cough, 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 cough. Which one is it? So it's called bronchitis, okay? But remember, tracheal bronchitis is the same name used for bronchitis. Asthma is not a dry, bothersome cough. It's more expiratory wheezing, and it's not, especially at night. And pneumonia, that's more of just a wet, juicy cough with a lot of secretions. A multi. Signs and symptoms would you see in a child with otitis media? Otitis media doesn't always have temperatures. Sometimes there is no temperature. Number one is absolutely that ear pain. Sometimes you'll see like the pus and serosanguinous dripping out of the ear, okay? And absolutely any infection, kids, loss of appetite. The monthly immunization for RSV is? Which one is that? And it's Synagist. Excellent. Good job. All of the following are signs of early respiratory distress in children, except respiratory distress. They're not getting oxygen. What's the body going to do? It's going to beat harder. It's going to become diaphoretic because you're working so hard. You're hypoxic, so you're restless. Bradycardia is late stages. So respiratory distress and your pulse is very low. This child is going to code soon. A 4-year-old child's been taking meds for asthma and the child is still wheezing. What information is important? What do you need to know? Something doesn't seem right there. They're taking the medicines. So sometimes 4-year-old children, have you ever used one of those meter dose inhalers? Can you push it and inhale at the same time? It's hard. So what they do is there's this little glass plastic tube, and on the end, there's a little hole. You put the meter dose inhaler. The end has a mask, and you put it up against the child. There's a tube, and you push 1, 2, whatever the dose is, and let the child breathe in and out about 5 times. Sometimes they're crying when you do it, but you know something? They're getting the medicine deeper. So what would you do first with this child? You get the spacer, bring it back, let the child use it, and see if there's an improvement. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Respiratory distress, substernal retractions, restlessness. Those are very classic. Children, unless they're below 90, we don't consider that hypoxic. A lot of times they do abdominal breathing, and a pulse 100 can be normal. And then the one in red is that could be normal also. Signs and symptoms of asthma include all except so we think of asthma, we know that's a lower lungs problem. Air goes in good, it sits there, and then it's trapped and it can't get out. So children and adults, they tend to prolong their expiratory phase to try to push the air out, okay? So it's trapped. It needs to work harder to get it out. It is prolonged. Yes, they're coughing, they're hacking, they're short of breath, they're wheezing, and sometimes it's audible, you can hear it. At least then you can wheezing, you can hear something in them, but prolonged expiratory phase. Signs and symptoms of congenital heart disease include all except so these children are working so hard, they're going to be smaller. They're going to be in the 25 percentile or even smaller than that because they're working so hard just to get the blood around and oxygen around in their body, usually never appropriate. They'll give these children high calorie per ounce, or even breast milk, put fortifier in, which increases calories per ounce. So the less amount of fluid, more calories, and it will help with nutrition. What should you not do to children diagnosed with croup and epiglottitis? Well, let's think. What is croup and epiglottitis? It's upper airway. What don't you think you should do there? Remember, they're already swollen. The epiglottis is already over the trachea. You can't breathe. You don't want to create any more inflammation. Do not look at the oral pharynx, no tongue depressors, none of that, okay? The epiglottis is the what? And yes, it's all the above. Leaf-like cartilage covers the larynx when you swallow so that you don't swallow food into your lungs. Yes. A multi. Treatment for infectious mononucleosis. Let's see if you remember. It's a viral disease due to Epstein-Barr virus. This is a common mistake. That's why this question is here. It is viral. Rest, antipyretics, no contact sports. It's usually like a sore throat. Yes, my dear. Iriona. Did you just put your hand up? Okay.
I'm sorry, I'm trying to wait until my daughter stopped crying. I was gonna ask, so with viral infections, you don't have to treat those with antibiotics at all?
Well, what's going to happen? It's a virus. Antibiotics are for bacterias. You're taking an antibiotic, which does nothing. Viruses don't have a cure. There's antivirals that we would use, like acyclovir, but we don't use antibiotics for a virus. And I know many times parents bring their children in and we tell them it's a virus and they're upset we didn't give them an antibiotic. I'm like, it's a virus. It's not going to work. All it's going to do is causing vomiting, diarrhea, and abdominal pain for your child. So we don't want to overuse it because when we need it for a bacteria, we want it to work. Okay? Does that help you?
Yes, it did. It did.
When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're doing an admission. This child's going to be placed on your unit. And they have a fever and a cough. Number one, what are you suspecting with this infant? So we don't need to know APGARs at birth. I mean, if there was a prolonged newborn intensive care unit admission at birth, yeah, you'd like to know that. But immunization status, this might be that one with pertussis, right? So always knowing that. What is their fever? And then, of course, what have you given them so that we can continue that here? Very good. What is cystic fibrosis? Again, multi-system, lungs, digestive system, and it's the small intestine. This is the pancreas, right? Anybody doesn't understand it, make an appointment. I'll explain it more. What is the greatest risk for an infant having a cardiac catheterization? What do I tell you I look at first? That's the biggest risk. It's all about bleeding out. Allergic reactions, I've never seen one. I told you, you might have decreased pulse after it, and that's normal. Cardiac dysrhythmias, very minorly, and usually only during the procedure, usually not afterwards. How is cystic fibrosis identified? I'll tell you a little trick. If you suspect cystic fibrosis on a newborn infant, tell the parent to lick their fingers and see if they taste salt. And they will. It'll be profound salt. So lick your child and taste salt, and that's your diagnosis. But no, what we do is there's a lot of newborn screening that's done and sweat tests. And they put a sticker on and they measure sodium content on the skin. That's all that's done with that sweat test. And I told you, this is a child who, if we didn't know they had the possibility of it, they wouldn't have a stool. They would, no meconium, nothing for the first like 2 or more days of life. And most infants do. A multi. What is included in a plan of care for a child with cystic fibrosis? So again, multi-system. So we want to take care of the lungs. We want to give the medicine so that we can digest some of that fat and decrease the bloating and the oily stools that they could have. We want to give protein, high carbs, and high sodium. Remember, they're sweating out their pores. What is the drug of choice for pharmacological closure of a PDA? So the patent ductus arteriosus is open and we want it closed. What's the medicine that closes it? And that is indomethacin. Prostaglandin keeps it open. Synagist is for RSV. Vitamin K is given at birth for the bleeding. And indomethacin is, or Indocin is the other name of it, that we give 3 doses to medically close the patent ductus arteriosus. What is not a feature of tetralogy of Fallot? Remember I said tetralogy of Fallot is all about the right side of the heart. It's the right ventricle, it's the pulmonary artery that all close up for some reason. So when you're looking at this question, what's not right-sided? And it's the aorta is not on the right side. That's the left side. So when the blood can't go to the pulmonary artery into the lungs, it stretches the left ventricle, right? The valve is either narrowed or shut off and blood can't go. All right. And many times tetralogy also has a hole between the 2 ventricles, a ventricular septal defect. It's 4 things that are with tetralogy. All right side. What medication would you hold for an infant that is vomiting? Vital signs are 98, 88, 32. What do you think's going on? And by the way, all these drugs can be given to an infant. You'd be surprised how many adult medicines. There's not specific drugs for infants. We use them, but in different doses. And that's digoxin. Again, you have an infant who's vomiting, you better go back and check the potassium level, check the dig level. I would hold the dose, call the doctor, be safe, don't be sorry. Why would a child with tetralogy of Fallot not gain weight at the normal rate? Why would any child with a congenital heart defect not gain weight? Very good. They're not eating because they don't have oxygen and they tire out. Absolutely. A multi. All are examples of cyanotic heart murmurs except I don't like this question. There's one wrong answer here. So we've already mentioned the cyanotic heart disease. It's very much done. is tetralogy of Fallot. And we also know that atresia or artresia here, it means there's no opening at all. So those are cyanotic because blood's not flowing to the lungs. A hole between the two atrium is extra blood flow going to the lungs, so that's over-oxygenated. And aortic stenosis just means it's narrow, but blood is still going out. We're still getting oxygen. What is the most common cyanotic congenital heart defect? I told you it's the one you have to know. And that's tetralogy of Fallot. Absolutely. Tetralogy of Fallot. Now, why would you pick PDA? Remember, what is a PDA? Think about it. It connects the pulmonary artery, oxygen, and it connects it to the aorta. So it gets oxygen to the aorta to the body. Okay, remember it like that. Nursing care following a cardiac catheterization. Everything but you don't want to ambulate that patient is absolutely, they're 24 hours in bed, okay? So you're going to assess that hematoma. You can slowly raise the head of the bed. And they say they don't want you to bend the right leg. You can, put it on a pillow, but they don't really want you bending and absolutely can't get out of bed 24 hours. And the reason is there's a clot on those two puncture holes. And if it pops off, the child will bleed out. Older children, right? I mean, if mom wants to hold the child, keep the leg straight. I mean, and that does happen. Another multi. Nursing education for the cardiac catheterization include all except. I know this is a very confusing remembering all this stuff. So cardiac catheterization in bed 24 hours and keep the legs straight. We will be monitoring the vital signs. Yes, they have a pressure dressing. And if they're older, a sandbag will be on there. Which information is the most important when rheumatic fever is suspected? So what causes rheumatic fever? And it is a strep infection. During this course, there's two diagnoses caused by a strep infection not treated. One is acute glomerulonephritis, which is the kidneys. That's week 8. And it's also with the heart, it can attack that mitral valve, and it can damage it. So these are the two with strep. So tell them to take all the antibiotics. Signs of shock in children include all of the following, except. And it's going to be hypotension, tachycardia, right? Altered mental status, poor capillary refill, decreased urine output, all of these things, and even, yeah, the altered mental, yes. Which of the following best describes the pathophysiology of Kawasaki disease? What is it? What are we concerned about? What was crazy is we had our director of the cardiac ICU, his 3-year-old son had Kawasaki, admitted one night, and I had to admit him. And that was my first incident many years ago, seeing what Kawasaki is. It's multi-system vascularitis, which means all the vessels are inflamed. We're worried about microembolize, and we're worried that it's going to bulge out, cause an aneurysm in the coronary artery. I remember he came in at 2 or 3 in the morning, and 7 in the morning when the cardiac office opened, he grabbed the echo machine to make sure that his son's coronary arteries are okay. I'll never forget that. Multi. A clinical manifestation of Kawasaki disease is all the above. And it's the chorea. What is that for? Rheumatic fever, right? So that's one of the other ones that students do get confused. Kawasaki is a viral infection treated with IVIG and aspirin or an anticoagulant, and the aspirin is there to prevent blood clots in the blood, okay? That was a HESI question. What is the treatment for Kawasaki disease? Aspirin and IVIG, good. No antibiotics this time. It's a virus. Excellent. Which of the following is the most common cause of shock in infants and children? And it is sepsis, or other words, infection. Infants do not tolerate it well. And as I said, the first things you'll see is the bradycardia and apneic spells, and they'll do a whole septic workup, including even spinal taps. They are that serious because they're so fragile. What are the defects associated with tetralogy of Fallot? Remember, it's right-sided. And the only other difference is that there's a hole between the ventricles, a VSD. So a TET spell happens when they can't get oxygen. So that pulmonary artery just closes, spasms, it's shut, blood doesn't flow. I've seen it go from 100% to a SAT of 10 in a minute. The child went from pink to black. It was impressive at 4 o'clock in the morning. Woke me up very quickly. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. You know, sometimes they don't treat them or have surgery when they're younger for whatever reason. And remember, what do we do if we know an infant's having a TET spell? And they do it naturally. They squat. All of a sudden, they're down on their knees. And again, it changes the pressure between the abdominal cavity and the chest cavity, and it will open it up and put blood flowing. Transposition of the great arteries is what? It's called a TGA. What happens with that? Remember, it's cyanotic because there's no connection anywhere to oxygen to the body. So the pulmonary artery and the aorta are switched. So what did we do for surgery for this child? Well, number one, we put them on prostaglandins, and we make that connection between the lungs and the body work, the PDA, right? Connects the aorta to the pulmonary arteries. Now we're getting oxygen around. And usually we'll wait a week. We'll even orally feed these usually normal, healthy newborns, except that their hearts are switched. So about a week later, it's not an emergency. We have them getting oxygen. they go to surgery and they do something called a switch. So they just literally pick them up, turn around, and put them back on. And that's called a switch procedure. Now, sometimes that patent ductus arteriosus still doesn't give them enough. Sometimes they'll take between the atrium. Isn't there a hole at birth called a patent foramen ovale? Remember that? Well, they make that bigger. They'll punch a hole in it with a little cardiac cath, and usually at bedside. They'll do that, open it up, make blood flow more. So transposition of the great artery, once we get them oxygenated, they do well. And post-operatively, of course, it is a hard course, but they mostly do well. Which of the following is not an intervention indicated for transposition of great arteries? So we need to have prostaglandins to keep the PDA open. We do the arterial switch, which is that switch procedure. And we also punch that hole between the atriums for flow. Oral anything, it's not going to work nothing on this child. It needs oxygenation, blood flow. A multi. Why is prostaglandins given to a child with transposition of the great arteries? You know that box that's sitting there in the picture? It's an external pacemaker, if you've never seen one. So we give prostaglandins because now we have oxygen going, and now the heart can work. Now, it's not an antibiotic. It's not an infection thing. It doesn't prevent anything. It gives oxygen and lets the heart now pump the way it should. Because it's got oxygen, it can work. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What does indomethacin do to that PDA? So this question is tricky. So we know we need prostaglandins, the medicine, to keep the PDA open. When the baby is intrautero, mommy produces prostaglandins, which keeps it open. Now, times it lingers around for some reason, and that PDA doesn't close. So when we give indomethacin, it says prostaglandin, stop, go away, you're done for. And then the PDA closes. Okay. Where is that patent ductus arteriosus? Let's see if you can recall now. What does it do? It connects the aorta to the pulmonary artery. PDA is about oxygenation, fetal circulation, getting oxygen to the body. Oxygen, pulmonary, body, aorta. And that's how you can remember. This heart defects allow blood to pass from the left ventricle to the right ventricle. So there's a septum, and there's a hole, and you have a right ventricle and a left ventricle. And that is called the ventricular septal defect. Well, if it was the right atrium and the left atrium, that would be an arterial septal defect. A multi. What is a sign of ditch toxicity in infants? Now remember, this is an infant. So adults see yellow spots. An infant can't tell you they see in yellow spots, but they can be retching and vomiting, and they can have a heart rate of 90. You can see that, right? And again, digoxin has nothing to do with infections. All about slowing and strengthening the force of contraction and let that heart beat more effectively. What is congestive heart failure? So the heart gets weak, or there's a kink, and it has to go somewhere, and it's going to fill up fluid into the lungs. Yes, it is. Rapid weight gain is one of the big first signs of it. Left-sided congestive heart failure causes what? This is like the coarctation. Blood can't go down, so it goes back into the left ventricle, left atrium, up into the lungs. What would it cause? Yes, all the above. Absolutely. Excellent. Good job. After a heart transplant, what's the leading reason children die? It's rejection. Now, you can treat an infection, but when your body rejects it, you can't treat it. You have to replace it. So that's why it's number one, and that's how you should remember it. Because I know students always mix up both of those. Rejection, because you have to replace it, and they die. They're not going to get another heart. A multi. Signs and symptoms of rheumatic fever include. It's not Kawasaki. This is now rheumatic fever. All the above. And remember, all of that stuff will go away with treatment. Again, what is treatment for rheumatic fever? Well, it was due to a strep infection. You treat the strep infection, long-term antibiotics. The only thing it won't cure is a cardiac problem. The mitral valve will still be damaged. A multi. A child's about to have a chest tube removed. What should you do? So you want to make sure that they understand. You're going to take their vital signs. You're going to medicate them for pain. You are absolutely going to tell them it's going to hurt, but not for long. Let's count together. Let's count to 20 together. And that child be sitting up, high Fowlers, would not be sitting laying flat. That burns and that hurts really, really, really bad. So again, they're not going to be in supine. A child just had abdominal surgery, cannot cough well enough to expectorate secretions. What is a nurse's priority? They need to cough. We need good pulmonary care, don't we? So, number one, you are going to give them pain medicine. How would you like to have abdominal surgery? Said, here's your incentive spirometry. Let's breathe in and out, right? Would that hurt? Oh, absolutely. So, in order to get more effective pulmonary care, medicate them for pain, get them out of bed, reposition them, use the incentive spirometry, cough and deep breathe in, okay? So does that make sense? An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Only acetaminophen up to 6 months. And at 6 months, you can add ibuprofen. And why is that? I've had parents ask. There's something to do with the bleeding coagulopathy of ibuprofen, and it causes prolonged bleeding, right? The end said. So that's why 6 months old, they can have it. A newborn infant is assessed, and the nurse finds very weak lower extremity pulses. What should she assess next? Well, number one, what do you think that is with very weak lower extremities? And what do you think you could do? You don't have machinery to figure things out. What would help you? You're going to do 4 extremity blood pressures. And why? The upper extremities are higher by at least 20 millimeters of mercury, and the lower ones are lower. Okay? That's when you say, yes, it's coarctation. Understand? I'll multi-select. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? So elevating the head of the bed, you don't know if you can or can't. So that's not like a common denominator. But yes, keep them dry, use incentive for spirometry, repositioning, turning, using, and in children, we use sometimes stuffed animals, pillows, blankets, depending on the size of the child, and it helps position them well. I know critically ill probably is intubated. I use little beanie babies. Parents used to always bring for the little babies. They'd put them there on the endotracheal tube to hold it good. And they're looking at this cute little beanie baby. So all of those things could be used. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? We talked about this one last week a little bit in the cahoots, and it is, yes, absolutely an oxy hood. You don't want to tape on the nasal cannula and it'll tickle a little nose. No, no, no. That little clear plastic, they can have a little pacifier and look around it, and it works beautifully. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, they're clogged with mucus. I mean, that's what cystic fibrosis is. Overwhelming mucus clogging things. I call it making petri dishes at the bottom of the lungs so that they can grow bacteria. And if we keep it up and moving and get it out, this child is so much better. So you won't ambulate PRN, you'll ambulate TID, QID. You wouldn't whenever they want, because that movement is good. Exercise is good. In fact, swimming is probably the best, right? Deep breathing, chest PT, exercise. Children with cystic fibrosis require pancreatic enzyme with meals. What teachings should be done? So the one thing that I have found in my career, not only with like cystic fibrosis and medications they take, I found it a lot with children with seizures. We forget, or the physicians, these children have growth spurts and we don't increase the dose. So again, remember, as children grow, the dose should be changed. And as I said, before meals, before snacks, sprinkle it. If they have powder, make sure they rinse their mouth. And it's within minutes before. What is the cardiac defect where there's no valve between the right atrium and the right ventricle? Well, what valve is that? And when there's nothing, what was the name I told you? And if there's a narrowing, what name did I give that? And you have the answer. It's tricuspid atresia. Remember, A without. Atresia, no opening. Stenosis is narrowing. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What does that sound like? And that's absolutely probably going in congestive failure, right? Listen to the lungs, you probably hear the junk going on. I mean, yeah, the heart rate's going to be elevated, but that's not going to tell you what it is. Breath sounds, you're going to hear the junk. Let's see how he did. Amber, good job, Amber. Number 2, Julie, good job, Julie. You listened well. Number 1, Brittany, good job. Sam and Austin. That was a difficult Cahoots. It's a difficult couple chapters. I think you guys did better than some other classes with it. I think I've given you all the keys and the clues of what you need to know. If you don't get it, come with me. I can tell you a little bit more about it, maybe explain it in a different way. But if you know that matching, those, names and medications, you should do pretty good with it. The pediatric assessment, I've gotten some of you to send in your diagnoses. Make sure, choose something that somebody you had something that a pediatric diagnosis that you want to learn more about. It'll make it easier on you instead of just a big chore. And remember, it's 3 parts. If you want, go ahead, start that paper, 250 words, send it to me, let me know. I'll grade it. I'll send it back. You can redo it if it needs it so that you can get the best grade you possibly can. I take this project as a learning. You send it early, I can help you, and then you could be prepared if you go on for your bachelor and your master's, okay? Guys, thank you so much for your patience in the beginning. Sam, thank you for calling me. I do appreciate that.
Welcome.
Y'all have a good day.